Everybody. Just want to take this opportunity to thank you for joining us, and I'm looking forward to sharing this talk. And if you have any trouble hearing us or with video, please use the chat box and let us know if you're having any trouble, and we'll do our best to try to correct that as best we can. I think what we're going to go ahead and do is I just want to make sure we are recording this, just so you know, so that we have it as an archive and you're able to watch it again or refer somebody else to it if you find it interesting, which I hope you will. So we'll go ahead and get started, and please do use the chat box if you have any questions during the talk, and we'll also open it up at the end as well. You should all be muted at this point just to help control the sound quality so everybody can hear, but we'll certainly find time at the end here to ask questions as well. So I'm going to go ahead here and just tell you a little bit about me. So I'm Steve Bowman. I'm a professor here at Boston College and the director of our Master of Healthcare Administration program, which is an online program that just launched recently. And we have a wonderful cohort of students currently in place, and it's a great place to be. And so we'll share a little bit more about that probably later on. But to give you a little bit of background on me, I have a PhD in health services from the University of Washington, where I also received my Master of Healthcare Administration, and spent a lot of time on faculty positions at Johns Hopkins Bloomberg School of Public Health, at the University of Arkansas for Medical Sciences, as well as working for the Washington State Department of Health for nearly 20 years, managing, directing a variety of different programs. And so part of that included some strong oversight roles over clinical data sets and administrative data sets for public health surveillance, quality improvement, and program evaluation, including the state EMS and trauma registries for Washington State. My research interests are in hospital outcomes and injury prevention and EMS and trauma systems, and specifically how we can identify ways to improve those outcomes through policy and changes in protocols and changes in the use of evidence-based medicine. So today we'll give you a little bit of an overview of sort of the history of big data in healthcare. We'll try to give you at least some understanding of sort of the demand, both current and future, for big data analytics and how those analytics are being used in healthcare. We'll talk a little bit about why you should care and why we should care as a society in terms of the use of analytics. And we'll examine variation in healthcare outcomes from both my research as well as some research of others. And we'll talk a little bit at the end about professional opportunities in healthcare analytics, including health administration management and how those fit together. So back in the beginning, in the 1960s, with the creation of Medicare and Medicaid, we saw sort of the original use of big data, which was primarily for billing. So providers and hospitals needed to be paid. And so we had fairly rudimentary billing protocols and procedures by which you could document the care that was provided, and hopefully, if all went well, get a nice check in the mail the old-fashioned way. And so clinical data were pretty limited in these original administrative data sets. It was really, what did you do? When did you do it? Maybe if you were lucky, having some semblance of outcomes related to it. But primarily this was for data, purposes that really were the result of the need to have billing recorded and billing processed. And so very few people actually had access to these data sets. And so you typically saw hospitals providing data in terms of hospital care directly to the payers, and ideally, if all went well, they'd get reimbursed. So I'm not sure if we're getting some feedback. If anybody's not muted, if you could just check your microphone, make sure we're okay on that. But also, back in the early days of big data, we had limited computing capabilities. So we think about how much we can actually process now on a smartphone, and the fact that the data processing capabilities of a smartphone typically consumed an entire room or more space back in the early days of computing. And so, big data, it was a challenge for people. We had a hard time actually processing data and using data. And there wasn't a whole lot of incentive to use big data. So we were a fee-for-service society with healthcare. What you did in terms of provision of care, you submitted the bill and you got paid. And we didn't have a lot of controls over the utilization of care. And so the billing part of it really didn't see kind of the need to have sort of a big data focus as well. So over time, what changed? So in the 1980s, when I started to get involved with health administration and management, this was the early, introduction of diagnostic related groups, DRGs. And so if you're familiar with DRGs at all, the concept is that you pay basically a flat amount for a certain diagnostic related group that would then result in payment to them, to that facility. And so rather than fee for service, you basically think of this as sort of a bundled payment for a specific diagnosis or a specific set of treatment. We also saw gatekeepers and quality review and managed care coming about in the 1980s. And so again, a real need to have data to be able to drive some of that oversight, more from a quality assurance function really than quality improvement at that point in time. And we also started to see pre-approval for care. So if anybody's had to contact their insurer before care could be provided in order to assure payment, that really started in the 1980s as part of the initial effort at managed care. But during the same time, we saw some pretty dramatic advances in computers. And so the personal computer came about in the 1980s, really, in terms of its prominence, and also advances in mini computers and certainly mainframe computers as well that provided a lot more capabilities in terms of being able to certainly manage big data, but also be able to process it in a way that we could actually get outcomes out of it and answer some of the questions that we might be interested in. So as a result, we have more demand for big data, at the same time, better accessibility. So it's easier to get data and more people are interested in it. But we still had some challenges. And so confidentiality of data remains an issue today. Who owns your data? And so how do we protect it? And so we have good, strong legislation such as HIPAA, so the Health Insurance Portability and Accountability Act, making sure that the right people are able to look at a record and the wrong people are not allowed to look at records. And so really dictating the exchange of privacy and confidential information. But data is still primarily proprietary in nature. So hospitals believe that they own their data and are reluctant to share data unless they're required to do so. And so you'll typically see state health departments or other oversight bodies that really require data submission and reporting, and that allows us to have big data available. But most facilities, if they had their way, would probably still limit the use of their data and certainly the sharing of their data. So, and of course, for patient records beyond the individual hospital level, that remains very difficult. You have really good detailed clinical records at the hospital level. The farther removed you get from a hospital, the more likely you are to have sort of billing level data, so administrative data, with less of that clinical detail that can be really valuable when you're looking at actual outcomes. And so, still primarily today, now I do a lot of my research in trauma and trauma care, and there are trauma registries that have much more detailed data than we see in administrative billing data, and that's a luxury from a data research standpoint, because we do have that available in certain registries, but in many data sets, we still lack that clinical data. And so, what happened in the 1990s, everybody, you're probably familiar with, in the 1990s, we had a huge IT boom. So we had computers and lots of capabilities and middleware vendors that were pushing all sorts of different products, and both from a hardware and a software standpoint. And you typically saw this approach where you had everybody trying to sell everybody something and really no roadmap as to where we were going. So we had one specific question about is there a course on healthcare data in the program, and our MHA program definitely does. We have a healthcare analytics course, which we'll talk a little bit about that later, perhaps at the end, where we do really predictive analytics, and we really provide that level of training to help you use data for decision-making and from a management perspective. We also have a healthcare quality management program, which is really, that course is designed to help you prepare to sit for a green belt Lean Six Sigma. And so you get a lot of heavy data use in that, and as well, and really looking how to do control charts and how to really use data in a way that can help you improve your performance at a provider level. So, the consumer protectionism of data, we've certainly seen pushback on that. And that's been one of our challenges with HIPAA, And oversight protections is that we want to be able to use it for research, but we still need it for the continuum of care to make sure that providers are able to learn from others that are within the continuum of care. So for example, EMS providers, I've worked with a lot of pre-hospital EMS providers over my career, and often one of the big criticisms that they have is that they take patients to hospitals, but they don't necessarily know what happens to them at the hospital level. So in other words, do they survive? Did they have a good outcome? Is there something that EMS could have done differently or better to improve the outcomes? And so the sharing of information across providers within that continuum remains a challenge today. Some areas do it really well, and others are continuing to struggle with some of that dynamic as well. But we also saw, sort of a pushback on managed care. And so the idea that we had gatekeepers, most of us in the public didn't like gatekeepers. And so we saw pushback. And so now you typically don't see that nearly as often as you did back in the 90s. And of course, to today, where are we now? Well, the Affordable Care Act is here to stay, despite what happens in the election here in just a couple of weeks. Some version of the Affordable Care Act as we know it will be around. It's just too big of a part of our healthcare system already in terms of covering the uninsured. And so there'll be continued pressure to increase access to care, to improve quality, and to reduce costs. So the three aims that we typically think of in healthcare. And so all this requires sort of, again, more of a attention towards the use of data to provide evidence. You're going to see more and more cost sharing by patients. And so we're already seeing that, high deductible health plans where, more and more you're seeing patients assuming more of that responsibility for potentially some big ticket items. And, high deductible health plans can work really well for people that are fairly well-to-do who can afford that and perhaps who can take advantage of the nice tax benefits that go along with having a health savings account if you're in a high deductible plan. But for lower income populations, the high deductible can be overwhelming, and in many cases by itself can lead people into bankruptcy. So lots of issues from a policy standpoint in that as well. So we want more value. We want to know that what we're paying for is actually worthwhile. And so we're seeing a lot of that coming from the employer standpoint, and no surprise, employers pick up a big portion of the check when it comes to health insurance for employees. And so there's definitely been more and more pressure to say, if we're paying this much, are we getting good value for that? Medical tourism. We see a lot of people that are going out of country to get comparable health care cheaper. So Costa Rica is one country that gets quite a bit of attention. India, Thailand, Singapore, many countries that are seeing some real movement in terms of tourism. And the idea here is that employers and health insurers potentially can pay people to go out of country to have their surgery or procedures done, and even paying for their travel and the care at that end can still save money by doing that. So the ability to compare outcomes to make sure that we know that there's the similar quality, whether you go overseas or whether you're having care here in the US, is becoming more and more important. And certainly having good data to be able to do that is essential for that. And so, I think here, this whole idea that we want to have benchmarks, and you've heard about health grades, and you've heard about even Consumer Reports now has, ratings of hospitals, similar to what we see for automobiles. All of this requires good data and people that understand how to use it. Okay. So why should we care? Well, in the US, we have, over 2 million healthcare associated infections each year. Up to 100,000 patient deaths that are due to medical errors each year. So if you think about that, you've heard quite a bit in the news probably related to gun violence recently, and you might think that there's 30 to 35,000 firearm-related deaths in the U.S., and of course injury is one of my areas, and that's certainly a very substantial number of lives lost. But when you think about potentially 3 times that number that are dying due to medical errors in the U.S., and this is a major problem. And preventable adverse events cost billions each year. And under the new policies, hospitals are not going to be reimbursed for preventable readmissions. So we need to have better ways of predicting which patients will require readmission and potentially being able to intervene so that we can prevent those and thus save money from the healthcare system standpoint. And of course, there's a lot of variation in surgical and medical treatment, and we'll talk a little bit more about that here in a minute. And that really leads to inefficiencies and waste in our system. And so we can do better, but we need to use data to drive our decisions. So John Wenberg is a health economist, and he's published this book, which is a wonderful resource and read on really looking at variation in healthcare. And so some examples that he's put forward through his research look at surgical variation and preference-sensitive care. And when we think of preference-sensitive in this context, it's the preference of the physician, not necessarily the preference of the patient. Right? So these would be seen, so prostatectomies range up to 19 times higher in some parts of the US than in other parts of the US. And of course, for most of us that, that are asked by our physicians whether we want a PSA exam to look at whether our prostates are healthy or not, there's a lot of variation in whether those tests are being used and to what extent. But certainly the consequences of prostatectomy are significant in terms of impotence and as well as incontinence for people that undergo that procedure. So really, really wide variation. Coronary artery stenting, 11 times greater in some parts of the US than others. And back surgery, often seen as perhaps discretionary in terms of whether that's the most effective treatment for back pain. Again, 5 to 6 times greater in some parts of the US than others. And to contrast that, so my area, I'm really looking at trauma and specific injuries. So for example, hip fractures are seen as less discretionary. If you break your hip, you really don't have a choice about whether you're going to have surgery to fix that fracture. And so those would be seen as less discretionary, and you would see certainly less variation as you would expect, and that is what we see. And then, of course, from a medical standpoint, you could look at cardiologists. And so the relationship between how many cardiologists are available in your community and how many visits to cardiologists that happen by Medicare enrollees in that area. And certainly you see that more cardiologists means that you're going to have more trips to the doctor. So there's a supply effect that goes along with that. And of course, end-of-life care ranges dramatically. And of course, that high-intensity care is not associated with better outcomes, including better patient experience. And so patient experience is strongly tied to certainly to quality, and more as we start to look at really how that relates to even outcomes in an acute care setting. A lot of this variation is questionable. And so we really have to think about whether this makes sense and whether we can actually identify some of it and study it and potentially reduce that variation and improve outcomes. So I asked the question here, and I think I'm very serious about it, is that if you were a hospital administrator or a clinician leader, would you want to know where your hospital or your group practice stands in terms of its performance and quality before reading about it in Consumer Reports or US News and World Report in terms of their rankings of top hospitals? How would you know that? And so the ability to have good healthcare analytics as part of your organization is really critical to be able to look at some of these factors up front and be able to sort of preemptively understand perhaps where you would fall within the rankings. So my research, I've spent a lot of my career focusing on acute care injury and trauma outcomes and really looking at hospital performance and what factors are associated with optimal outcomes for injury and trauma care primarily, but also some for cardiac and stroke care. And I'm really interested in quality improvement and how do we adopt quality improvement practices in hospital settings. Excuse me. And of course, today, the hospital physician dynamics and how that's changing. It wasn't that many years ago when we had individual physicians practicing in sort of private offices and perhaps even solo practitioners. And with mergers and consolidation, more and more employees of hospitals we're seeing now for physicians. And so we're seeing a real change in the dynamics of that relationship between hospitals and physicians. And so I'm real interested in how that relates to outcomes and the ability to actually implement evidence-based practice. So I published in a whole variety of different journals with many clinical colleagues, and so that's one of the fun parts about working in this area is that from a healthcare administrator standpoint, if we have good partners who are clinicians, we can ask more difficult questions that I could perhaps answer on my own. And I can bring some analytic skills to the table that many of my clinician colleagues do not have. So it works out to be a really nice partnership. So here's just an example of a study that I did. This is a big data study using hospitalization data. We're looking at whether we have trends in pediatric drownings over a 16-year period. And what we found is that at hospitalizations, if you look at the rates of hospitalizations among children, that it dropped by half over the 16-year period. Now, I show you this not necessarily to talk about that particular study itself, but really thinking about the data that's involved with this. So each year of hospitalization data that I used was anywhere from 2.5 to 3 gigabytes of data. So we're looking at a 50 gigabyte data file. So for the average person on a personal computer that might want to do kind of analytic work in Microsoft Excel, this might not necessarily be the right data file for you. And this might be a little bit too much in terms of, of computing requirements to be able to really take this on. So big data requires some specialized skills, doesn't necessarily require that much specialized equipment, but clearly we need to have the right tools in our toolbox to be able to analyze this type of data. So the other one area just that I've spent a lot of my career on with my clinician colleagues and is looking at pediatric spleen injury management. And so the spleen has a very important function in children, especially in terms of immune response and protecting children from infections. And excuse me. And conservative management of pediatric spleen injuries has been shown to be successful in over 90% of the cases. And most recently, the evidence says that it's probably closer to 95% of kids who experience a spleen injury can be managed without having a splenectomy. In other words, without having their spleen removed, they can have very good outcomes. And the evidence-based practice guidelines are strongly recommending that conservative management is the approach that should be taken for all children that have relatively stable vital signs. So hemodynamically stable patients, that means their blood pressure is relatively stable. There's really no reason to be taking the spleen out. You can manage them non-operatively and they'll do just fine. And yet we found that there's wide variation across the US in terms of how children are being managed. And that was one of the things that got me interested in this, was that the question is, well, if it's a similar injury, why is such variation occurring and what can we do about it? And so we know that, perhaps general versus pediatric hospitals, there might be a relationship there in terms of where children are receiving care, as well as the ownership. So in other words, are children doing, are they receiving different care if they're in a not-for-profit hospital versus a for-profit hospital, and what motivators might be driving the clinical care in these types of settings. And so conservative management is important primarily to avoid overwhelming post-splenectomy infection, which we call OPSI. And OPSI is certainly something that if you lose your spleen as a child, you're at risk for OPSI, not just for in the days and weeks, but sometimes years and years later you can develop OPSI. And we care about OPSI because even though it only happens to 1 to maybe 11% of children, if you do get OPSI, for children, mortality can be up to 50%. So this is a very important condition to avoid, and so helping children retain their spleens is a good way to prevent OPSI. And in addition, we avoid surgery costs, and there's fewer blood transfusions and shorter hospital stays. Lower mortality, decreased drug use that's typically seen for prophylactic antibiotic therapy to avoid prevent infections. And so all these factors make conservative management highly desirable in children. And of course, well, why do we care about this? Well, there's roughly 1,700 splenectomies being performed each year on about 7,000 hospitalized children with spleen injuries. That's a 76% conservative management rate. If we can get that to 90%, which is where we should be, or even higher, we could prevent as many as 1,000 splenectomies each year. So a pretty significant number. So using data from the Healthcare Cost and Utilization Project, this is hospitalization data from states all over the US, we were able to identify hospital characteristics, excuse me, including ownership and hospital type to be able to explore some of these relationships. Multivariable logistic regression, really using some advanced methods to make sure that we're adequately controlling and comparing children with similar injuries across the hospital setting in which they're getting care. And so this first paper that I published in JAMA, it's been just a little over 10 years ago, that really looked at hospital characteristics associated with spleen management in children. And what we found is that just looking at general hospitals compared to pediatric hospitals, a child with a spleen injury was 5 times more likely to have their spleen removed if they were cared for at a general hospital as opposed to a pediatric hospital. Pretty dramatic difference in management practice. And so, this certainly led us to believe that there's some significant quality improvement opportunities in this area. Perhaps educating physicians in these general hospitals, could lead to a greater use of conservative management in children. Of course, just looking at general hospitals versus pediatric hospitals is only one part of the equation. There are no for-profit pediatric hospitals. So pediatrics is typically not a big moneymaker for hospitals, and so you typically only see not-for-profit children's hospitals around the US. And so in this study, we looked at just general hospitals. We took out the pediatric hospitals and said, well, for general hospitals, do for-profit hospitals behave differently than not-for-profit hospitals? And in this case, we found that children receiving care at for-profit hospitals were twice as likely to receive splenectomies, to lose their spleen, than those children who were cared for at not-for-profit general hospitals. So again, some other indications that we have some opportunities for improvement by reducing this variability of care. So in Washington State, we spent quite a bit of time looking at the state trauma system and trying to identify where the opportunities were. And so we took on a statewide quality improvement initiative where we educated surgeons and trauma hospitals on their current state of pediatric spleen management. And so we gave them data reports that compared their performance in terms of spleen management, splenectomies versus conservative management, with other hospitals in the state, with other hospitals at their similar levels of trauma designation in terms of their capabilities to provide trauma care. And we provided evidence-based practice management guidelines and education to help them improve their knowledge around this area. So what we found doing a pre and post here is that our initial thought was that we would change surgeon behavior and we would see more surgeons in general hospitals managing pediatric cases non-operatively. In reality, what we found is that after the intervention, surgeons in general hospitals were much more likely to transfer children to pediatric hospitals. And so we saw that as real success. In other words, they weren't necessarily willing to manage a child non-operatively. And again, surgeons primarily are trained to do surgery. So you can understand that if you're in a general hospital without pediatric capabilities, watching a child in an intensive care unit without pediatric specialty resources, can be a bit concerning and scary for a general surgeon. And so the fact that they were able to really see a change in transfer behavior so that children were not losing their spleen, they were getting the right level of care. Perhaps it wasn't in that community hospital, perhaps it was at a pediatric center, but nonetheless, the outcome is good for the patient. And so then we also took the next step and so we did a national survey of looking at general surgeons and trying to identify, sort of variability of pediatric care and what were the drivers behind that. So, on a very sort of, suspicious kind of thought, I thought, well, maybe surgeons are doing, splenectomies because they make more money off of doing splenectomies. You certainly have greater revenue charged when you do a surgical procedure than if you watch a patient in a non-operative manner. But what else is going on with this? And so we really tried to identify their level of knowledge about the evidence-based practice guidelines, what other factors might be behind their decisions to manage with splenectomy or manage non-operatively. And it was really interesting because we found that a lot of it had to do with, whether that hospital that they practice in really has pediatric specialty capabilities. And so, excuse me, you really have to understand that there's so much knowledge out there that physicians are expected to now know. Really having a good grasp of clinical practice guidelines can be difficult. There's so much turf to cover. So this was just another example. And so, so the future of big data. So I don't know if people are familiar with Epic. Epic is one of the larger electronic health record systems that's out there. Partners Healthcare here in the greater Boston area just spent roughly $1 billion to implement Epic across all of their hospitals and providers. Huge investment in the infrastructure to be able to do this. Growth of analytic capacity is tremendous. And so we're seeing more and more hospitals with Epic and other electronic health record systems now trying to figure out, how do we get data back out? So we know how to put data in, we know how to capture data, we know how to enter it, we know how to convert our traditional approaches to maintaining patient records into an electronic format. But now how do we analyze the data? How do we make sense of it? How do we use it to improve care? And of course, claims data, is becoming more readily available. You can get national claims data sets now, which you never could in the past. And of course, again, more push for transparency means, more and more of this data becoming available in a less restrictive fashion. But we really do need trained people that understand both the clinical and non-clinical aspects of this with the analytic training, so they actually are able to put the data to use. So I typically like to talk about what I call bridging professionals, which is that we have people that understand the clinical side as well as potentially understanding information technology, and so the analytic skills that can bring this across in a way that can make meaningful use out of the data. We have a healthcare information systems course in our MHA program that really is designed to help explore some of these issues in terms of capacity and the skills that are out there in terms of really being able to build this kind of infrastructure within healthcare organizations. But we're going to see more and more transparency. I mean, it's pretty easy right now for you to go out to Angie's List and get ratings of providers, but at a hospital level, it's not always easy to be able to identify, is this hospital, does it have better outcomes for this type of surgical procedure than the next hospital down the road? It's not always that easy to see it. And if they're comparable, do you know how much one hospital will charge you and how much the other one will? Often prices are not transparent at all. And so not only do you not have outcomes data, but you may not really know what it's going to cost you outside of your insurance. So we want more value. We want to know what we're getting. We want to be able to say, hey, we're in the driver's seat as consumers. We want to make sure that we can actually make sense of this and have the good data and the tools available to make good decisions. And so you're going to see more and more of this over time. And I think that's an exciting time for those of us that are interested in data-driven decision-making. And so, I had one of my friends who's the CEO of a large academic medical center in the South. She came and did a guest talk in my class, and she said to my MHA students, she said, if you provide me with 6 highly trained health analytics professionals tomorrow, I will hire all of them. And this is right after she went through an Epic electronic health record installation implementation for that hospital. And it was obvious to her that she needed people that are in healthcare management that have analytic skills that can really make sense of this wonderful data. And so that's what I have for you tonight. I wanted to open it up for questions, if we have any more that have been coming in. If you have questions about this or questions about our MHA program, I'm happy to entertain any of the questions here. So one question that just came in had to do with how these positions fit within the health administration curriculum. And so again, I mentioned we have several classes that are really analytics focused. I mean, we have a healthcare analytics course, we have healthcare financial management, we have our healthcare quality management course, we have strategic planning and marketing. I mean, all of these courses will use big data and will use data to really provide some of that application. And so we're very focused on providing real activities and real projects that you would typically see in the career positions where you're looking to go with this degree. So it's kind of a nice approach to be able to sort of tie all that together. And so we also have, as part of our program, we have an immersion course where it's really focusing on innovations, where students come to the Boston College campus one time during the program, and it's really for a long weekend, and we bring sort of healthcare experts and leaders together to really tackle real-world projects as teams in this environment. So a lot of this is being driven as well by that. So we have 6 starts a year for our MHA program. So if you're interested in our program, we'll have another start coming up here in January. And it's really a rolling process. We do require some healthcare experience for our program. The good news is we don't require a GRE or a GMAT score. And we really do look for people that really have a commitment to healthcare. Our program includes sort of a focus on Jesuit values, as Boston College is a Jesuit school. And so we help individuals as leaders be able to think critically beyond the nuts and bolts of whether a decision is the most cost effective, but also being able to factor in how does it impact the human side. And that's something that we as healthcare leaders are often addressing in our decisions, is that whatever we do that looks like it has a financial impact really does affect people as well. And so by thinking a little bit deeper and coming up with sort of better critical thinking skills, we can come up with additional alternatives that perhaps can both maximize our profitability as well as maximizing the outcomes in terms of real people. So that's kind of our goal with the program. And I think it's really an exciting place to be, because many of the MHA programs really don't have that piece. They focus simply more on the business side of it. And we really want to develop whole leaders that can be successful throughout their careers. So we have a question so far. Let's see, about how long does it take to get a program CAMI accredited? Will this program receive accreditation in the near future? So our commitment at Boston College is to obtain CAMI accreditation. We can't actually sit for CAMI accreditation until we've graduated our second class. And so the design of the program is built to be completely compatible with the expectations of CAMI. And so we're a competency-based program. All of our students have an executive coach that's assigned to him or her throughout the program to help you succeed in the program, as well as to be able to plan your career post-graduation. And so the pieces are all there, but the question around CAMI is one that is always related to working through the process as well. But if you look at the design of the program and the commitment from Boston College, this is where we want to be. Let's see, other questions? Group. So I would encourage you to certainly feel free to reach out to me as well in the future. You've got my email here. If you have questions about the program, or if you want to talk about big data or trauma data or trauma systems, I'm always happy to talk to folks about that as well. Let me just check. I think I might have one more question here. So the question about U.S. News and World Report rankings, I'm not sure about that in terms of how it will show up with the rankings, because it's a new program. It takes a little while to get established on that one. And so the question, I think, from one individual about health informatics, you've taken MS Health Informatics courses before, or any of the credits transferable. Courses are all going to be, if you have specific courses that are equivalent, we'll certainly consider up to eight credits in transfer, but they have to be equivalent, and so our courses are a little bit different. So please feel free to reach out to me if you have questions about whether a course might be transferable and whether it be equivalent. So we really have to look at those on a case-by-case basis, and we would be asking you for some details about that other course that you might have taken. So another question has to do with, could you spread the program across 5 years? You could certainly do that. Our program, if you took one course at a time, is designed to be completed in 2 years, but you could certainly take fewer and spread them out. We certainly are a flexible program that allows for people to be able to go at their own pace, so we encourage that. And let's see, does the program focus on data analytics or executive decision-making from data? So Um, that's a question that we really talk about in terms of it's not an analytics degree. I mean, it's an MHA program degree that is general, and so we're covering the full spectrum of the competencies that you need to be successful in your careers in health administration. And so it's really a mix. I mean, there are three courses that are more quantitative in nature. And certainly the healthcare analytics course is very specific in terms of that. And we really, if you haven't had college level statistics as an example, we have a free statistics primer that we might require you to do for the program. It doesn't cost you anything, but it's really designed to make sure that you're prepared and that you can succeed in that healthcare analytics course primarily. And so the prerequisites that for the program itself, we take people from all different undergraduate degrees. And so we have people from liberal arts, we have people from undergraduate business administration, we have clinicians, we have nurses, we have a physician CEO that's in the program right now. So you really can come into the program from any different angle. And really the only prerequisite is going to be if you haven't had college level statistics, we'll give you a primer to do to make sure you're up to speed and you can succeed in that program, in that particular course. So I'm not sure, did I miss any other questions? Anything else you're thinking of there? I'm not seeing anymore, but I would encourage you to feel free to reach out to me, and if I can answer any other questions about the program, and I'm always happy to do so, and shoot me an email if you like, and I'm happy to schedule a time to talk with you about it. And as program director, happy to talk about my vision for the program and what we're about and how we want to see this program succeed as we move forward. So I'm just looking at the chat box and I'm not seeing, so you're asking what my vision is. So my vision is that we will be a top 10 ranked CAMI accredited MHA program. So Boston College is committed to being the best, and in terms of online education for MHA programs, there aren't very many online MHA programs that are accredited by CAMI. So it's only recently that CAMI began to accredit online programs. And so our balance is really strong in terms of being able to have a mix of asynchronous and synchronous sessions. All of our classes have a 2-hour live session once a week in the evening, one evening a week, where you'll spend live time online with your faculty member and colleagues doing real discussions and engagement. It's very different than kind of an asynchronous model where you're sitting back and doing everything on your own and not necessarily having the real dialogues and discussions that you see through a live session like that. So I think the competency-based approach is really critical. We have an industry advisory board that is critical to us in terms of making sure that our competency model is relevant and aligned with what their needs are from the employer standpoint. And so we take that very seriously in terms of how we map our competencies for each course, and so that we make sure that throughout the program, you're building on those skills. When you finish our program, you'll get an academic transcript, which shows your course grades. You'll also get a competency report card, in a sense, that shows how you've attained your competencies. And that's something that can be useful for you when you're discussing with employers and potential employers the kinds of skills that you've gained through our program. Other questions? Well, I sure appreciate you spending the time and letting me share some of my research and some of my thoughts about big data. And it's a fun area, and I think that if you certainly would be wise to kind of explore as you're looking at health administration programs, just the kind of resources that are behind it in terms of being able to offer the kind of analytic training that goes along with it. So our courses are all online except for our short immersion course, which is held over a long weekend at Boston College. So we want you to come to Boston College once during your time in the master's program. And that's really, there'll be some prep work that's online, but the idea that you can come together with some of the top healthcare leaders and really join your colleagues to be able to do some real world projects is an attractive part of our program. Boston College is a beautiful campus, and when you become a Boston College student, as part of our program, you're entitled to all of the benefits of being a Boston College graduate student. And so if you want to come to campus and go to football games or hockey games or be a part of performing arts on campus, you have lots of options available to you. And so even if you don't live in the Boston area, if you're visiting, you are a full Boston College student as part of our program. Any other questions? I'm not really seeing much, but if feel free, and I appreciate you you all joining us tonight. And if there's no other questions, I think we're probably ready to wrap up for the night and let you go watch reruns of our election debates or whatever else you might want to do tonight. So thank you again for being a part of this. And I'll let you go. Have a good night.